welcome back. It's great to have you. Everyone, please welcome Dr. Santavicca.
Thank you, Dr. Winters, for the warm welcome, and I can't express enough how much of an honor it is to come back here being asked to talk about one of my favorite topics and be included in such an all-star cast. So thank you, it's humbling, and I appreciate it. I hope you learned something here. So I was asked to talk about capnography, and it was one of my favorite topics because I think it's a quick and easy tool that we can get a ton of information for. And I think it's underutilized across the entire medical system, from the pre-hospital setting into the ICU. So I'm hoping I can teach a couple things here that you might be able to take into your next shift and help save a life or help a patient. Okay, I have no financial disclosures. Breeze through that. So I like to get my learning points up front. So there's a lot here, but I'm hoping to convince you of and show you some literature as to some of the important points here. So we're going to start off the talk by talking about a little bit of physiology and how capnography is determined by three major factors. And we'll go into depth of that and kind of lay the foundation as to how that affects the utilization and usefulness of capnography in different patient populations. We'll start off by talking about procedural sedation, and in capnography, in procedural sedation, it will help you catch hypoxic episodes and prevent ventilation assistance in procedural sedation. During intubations, it is widely recommended that we utilize that a capnography for confirmation of tube placement and monitoring of tube placement. Capnography in cardiac arrest, the usefulness and the information that it gives us to help guide the arrest and portend a little bit of mortality as well. And then for sepsis, near and dear to my heart, the ability to diagnose, predict mortality, and help guide the resuscitation through the department and potentially in the ICU. Okay, so I want to take you on a journey of CO2. It originates as a byproduct or as a product of cellular respiration by the mitochondria in our tissues. It gets transported by our cardiac output in our heart, ultimately to end up in our lungs. And through ventilation, expelled through our lungs, and then the CO2 that's produced is detected by the CO2 detector. Any derangement or dysfunction in any of these systems can alter the CO2 that we detect in end-tidal CO2 and can give us insight into some of the hemodynamics and lung function within the patient. Particularly with the lungs, in addition to ventilating and actually respiring and expiring, metabolic dead space and physiologic dead space is a key important component to determining end tidal. So the first part is the anatomic dead space. Everybody has it, it's fixed, it's about 150 cc's, comprises the oropharynx and the upper airways. They do not participate in any gas exchange. So as mentioned, I think by Dr. Allison, the dead space, it can be stale air and mix within the air that is undergoing gas exchange. And then physiologic VQ mismatch, perfusion ventilation mismatch, goes across the entire lung space. So divided into different zones, the ventilation and perfusion is highest at the apex, where gravity will pull blood flow to the lower portions of the lung and maximize our ventilation perfusion ratio. In the middle portion of our lung, it's a little bit more equilibrated, so we have a relatively stable VQ matching. And then at the base of the lungs, both ventilation and perfusion actually increase, but perfusion increases dramatically relative to ventilation, so your VQ ratio actually decreases. So depending on where the physiologic disturbance is within our lung can impact our end tidal CO2. And the amount of dead space, so in our alveolar units, our functional alveolar units, we have the blood-gas exchange. CO2 can go into our airways and then expire. In areas where there are a lot of dead space, both physiologic dead space and anatomic dead space, you're going to have this stale air not mix and dilute out the CO2. So end-tidal CO2 is a kind of an average of all of the functional units of our lungs. So if you have a lot of dilution of that CO2, you're going to have what's called a CO2 gap. So end-tidal CO2, this is a normal waveform here. We'll go over that in a second. And then the arterial CO2 can be potentially a lot higher depending on how much dead space we have in our physiology. More dead space, that gap increases, okay, from what we're detecting. So it's a good idea to have it's good to have an idea of the amount of dead space per patient to kind of give context to the capnography readings that we're getting. Okay, so now going over a waveform. This is elementary, brief, but I'll keep it brief. Zone 1 is our inspiratory phase, so it's our baseline here. It's usually pretty low. The second part of the capnography is the beginning of expiration, and represents the anatomic dead space, clearing of CO2 from the anatomic dead space. So you have a rapid rise in CO2 by the detector. You do create an alpha angle here between the second and the third space here. You want it to be nice and sharp and create a plateau into the third space as we're entering the alveolar gas exchange and the gas of the lower airways that are participating in gas exchange. Ideally, you want it to be plateaued and straight. And then during the beginning of inspiration, you have a sharp decline. This second angle, the beta angle, is kind of where we get the capnometry reading. The value that you see on your capnometry reading, that's the value that you're getting. It's usually the peak. And then this waveform is capnography. So it's important to know not only the number, capnometry, but also the waveform, the capnography. Okay. All right, so with this in mind, let's dive into the literature. So particularly with procedural sedation, we're trying to take advantage of the fact that CO2 diffuses about 20 times more than oxygen. So you're going to equilibrate the CO2 a little bit quicker during procedural sedation. Procedural sedation also limits your respiratory drive. So hopefully we're trying to catch the problem of hypoventilation earlier before hypoxia takes into effect, right? So this actually bears out in the literature, where there was a meta-analysis, 13 studies, I think it was over 1,000 patients. And here is the forest plot of mild hypoxia and desaturation, less than 90%, and then severe desaturation, less than 85%. Both trended towards using capnography with a risk ratio of 0.77 and 0.6, about a 30 and 40% reduction respectively for both of those. And then in the same study, it also favored assisted ventilation with an odds ratio of about 0.47. So about a 53% reduction in assisted ventilation during these procedures. This not only included emergency department patients, but outpatient clinics, colonoscopies, GYN clinics as well. All right, so about decreased desaturation events and needing ventilation assistance. Okay, so intubation. When we intubate, we receive a lot of, in New York, we receive a lot of preclinical intubations by EMS. And sometimes there are going to be some missed intubations as high as 5 to 10%, in some studies even 20% missed intubations in the field. And it's important for us receiving critical patients in the emergency department to identify missed intubations or esophageal intubations, and even in the emergency department. Critically ill patients, we want to identify if the tube is in the right spot. Okay, what we want to do is we, again, want to look not only at the capnometry, the number, but also the waveform. And there can be some some falsely reassurance if people use calorimetry, so the color changing after you intubate, the turning yellow after a couple breaths. There have been some false positive results in the esophagus from pre-medication, pre-bagging, and you could be falsely reassured. And then later on, find out that it's in the wrong spot after the patient desaturates or has a bradycardic event. So what you want to do is you want to look not only, sorry about that. Okay, you not only want to look at the number, you want it to be consistent, you want it to be increasing value and a normal value around 35 or 40. And also, more importantly, the waveform. So you want the waveform to be nice and squared, you want it to be consistent, and you want to have a nice plateau square form. The bottom area shows what can happen in an esophageal intubation where it might start off okay and then it's a little bit rounded, narrowed, and then will decrease over about 4 or 5 breaths. And there are some studies showing that reviewing an EMS, a large EMS body of evidence with the pre-hospitalization intubation showing decreasing esophageal intubation rates to 0.3% using end-tidal CO2 to confirm placement. And then an EMS trial showing 0 missed intubations versus 23% missed intubations when not using end-tidal. And then Gurmek used a nice pre-hospitalization intubations review comparing CO2 detector, esophageal detector, and auscultation. And all did okay, but end-tidal did the best with the sensitivity and specificity of 100% and 100% positive and negative predictive value. So despite that, there are some studies that show some shortcomings with sensitivities. So many of the studies across all different pre-hospitalization settings, if the tube is in, you're in. So the term that I've heard and seen used is right place, positive trace. So if you have a good tracing, you're in the right spot. There are some studies that showed that the sensitivity can fall off. So you can give, you might be in the right spot, but for some reason, the tracing isn't positive, usually due to kinking. You can have a balloon malfunction. So there are some, the thought is unless you can really hone in and evaluate that patient quickly, assume that it is out of place, take it out and reattempt an intubation. Some studies show anywhere between 50s and 60s sensitivity with placement of the ET2. So despite this is probably a golden ticket, and it's been recommended by major societies, including ACEP and the AHA, to use end-tidal to confirm the ET2 placement, because if it's in the right place, you got a positive tracing. Despite this, there's the end-tidal capnography is widely underutilized, especially compared to that calorimetry that we were talking about. It's a 3-to-1 ratio in over 500 hospitals that were surveyed. Almost 60% rarely or never use end-tidal in non-cardiac arrest patients. And about 12% only use capnography for intubations. So it's scary. And one of the biggest things that I can impress upon is to use it, use it, use it. Now with cardiac arrest. Going back to the journey of the CO2 slide, it is vital that the end-tidal is determined by the cardiac output. So if the cardiac output is dysfunctional or you don't have a perfusing rhythm, your end-tidal is going to fall off. So this was actually a porcine study where they took pigs and induced a non-perfusing rhythm. So ventricular fibrillation, and you see that the end-tidal fell off dramatically. Maintain somewhat of a perfusion with CPR. We are able to try and maintain a certain percentage of end-tidal, and that's the goal with why we're doing CPR. So they maintained CPR and then defibrillated back into a perfusing rhythm, and the end-tidal jumped. So this kind of correlates that perfusing rhythms are affecting end-tidal CO2. Now, early in cardiac arrest, we want that CO2 to be high. If it is not, we are concerning that there's not a perfusing rhythm and potentially cellular reproduction or cellular respiration is down, right? So we really want to get that up. So this study was about 110 patients, and they were undergoing cardiac arrest and took an end-tidal CO2. And they basically showed that if your end-tidal CO2 is less than 10, you had a very poor prognostic indication early on. If you had an end-tidal CO2 that was greater than 10, you had 18% odds ratio of retaining ROSC and a negative predictive value of 92.92. Okay. Now, as arrest progresses, we want that end-tidal to go up. If it is still maintaining low, again, very poor prognosis. So within another study, within 20 minutes of ACLS, they showed a big discrepancy between the survivors and the non-survivors. So about 33, the end-tidal for survivors were about 33 as opposed to 4 or 5. And here is a tally chart showing what the end-tidal CO2 levels were of the patients that expired outside the hospital, so less than 10, and then ones that survived to hospital admission were all greater than 20. No one survived with an end-tidal of less than 10 at 20 minutes. Now, how do we do that? What are the pillars of cardiac arrest? It's early defibrillation and it's good quality CPR. So as you can imagine, good quality CPR will help rise your end-tidal CO2. You're trying to mimic that perfusion rhythm. And this study actually shows that the depth of the chest compressions made your end-tidal CO2 rise. So here at the bottom is your depth of chest compressions and then your end-tidal CO2 level. With each increase in depth, you had a rise in CO2. And then the color coding here basically shows that we're being taught the right things. Chest compressions between 100 and 120 had the highest rise in CO2. So deeper and anywhere between 100 and 120 will give you the best chance of getting your CO2 to go to increase. Now, as we saw with the porcine study, if you're achieving ROSC or about to achieve ROSC, your end-tidal is going to spike up now that it has a perfusion rhythm. Tissues are going to be perfused, they're going to offload the CO2, and you're going to be able to get that CO2 to the lungs. So you're going to see a rapid rise in end-tidal. And this study basically shows that with the rise of end-tidal CO2, with the increase in the rise and the value, your specificity goes up and your negative likelihood ratio goes up. So if you can get that end-tidal to increase by 20, or you see that on the monitor, you have a good chance of achieving ROSC. And by doing this, rather than doing the pulse checks every 3 minutes, you're maintaining a good chest compression fraction, and you're limiting times when you're interrupting CPR, which, as we know, is one of the most important factors and predictors of achieving ROSC. Okay, so this is different portrayals of survivor and then non-survivor. The 0 time is when ROSC was achieved, and you can see here that leading up to ROSC, the end-tidal was rising and then kind of plateaued off. For non-survivors, it either maintained at a low level or petered out as the arrest went on. And some people think that it's because your cellular respiration is starting to slow down and you're not only not generating CO2, you're not getting that back to the lungs. So your end-tidal is going to read a lot lower than what your arterial CO2 is. Okay, so for cardiac arrest, it's going to confirm ET2 placement. It's going to give you an idea of how you're optimizing your CPR early on. If it's rising, it might give you a good idea and correlation of ROSC. If it maintains low throughout the resuscitation, it is a poor prognostic indicator. Okay, so now sepsis. So sepsis has always been kind of the holy grail of EMIM because we've gone through many renditions of how to identify it, how to diagnose it, who's really sick, who's not. We try to use vital signs, we try to use lab values. And it's always been tough. You're either super sensitive, not specific, or you're very specific and not sensitive. I'm going to argue that end tidal could be, potentially, another vital sign. Maybe the sixth vital sign. We say glucose is the fifth vital sign. This might be the sixth vital sign in helping determine who might be sick in the pre-hospital and early resuscitative setting and then manage them accordingly. So it goes back to this. So any derangement in our cardiovascular output or our perfusion is going to affect our end tidal CO2. So with sepsis, if our CR2 is low, that could tell us that the patient is sicker. So in this study, they compared SIRS, they used SIRS and end tidal CO2. So they created two different groups. 2+ SIRS and an end tidal that was low versus they did not meet SIRS or their end tidal CO2 was elevated. So EMS picked them up, they got their vital signs. If they suspected an infection and were SIRS positive, they took their end tidal CO2 and measured it out. Turns out that in the patients that had, so the protocol compliant patients are the patients that had the CO2 that was low. Turns out that they had a higher diagnosis of sepsis, they had a higher diagnosis of severe sepsis, and a higher likelihood to be admitted to the ICU and to the hospital itself. And then they had different values. So 33 for the non-protocol compliant, and then 20 for the protocol compliant. So less than 25, greater than 25. And then we're about to see a lot of receiving operating curves. So here it's really tough. So sensitivity on the y-axis, x-axis is 1 minus specificity. We want to be in the upper left-hand corner. And as you can see here, it's tough to see, but your end tidal CO2 is in the upper left-hand corner. So it has an area under curve of 99% for sepsis diagnosis. For severe sepsis diagnosis, it outproduces any vital sign in the pre-hospital setting. And this is another study by Hunter coming across the pre-hospital setting, sepsis and capnography. If anybody wants to read about it, Hunter's the guy. He has about a study every 2 years, kind of indicating different uses and predictors with end tidal. So this is a 2018 study, about 300 patients. He now compared end tidal to Q-SOFA. So people with Q-SOFA criteria greater than 2, suspected infection, and then did the same thing. End tidal less than 25, end tidal greater than 25. And as you can see here, people with sepsis and severe sepsis, end tidals were lower, statistically significant. Lactates were higher, statistically significant, and bicarbs were also lower. So it correlated with higher ICU admission, higher mortality, higher lactate, more acidosis, and then the lower CO2. So this could be potentially a missing link in helping identify sick patients early in resuscitation, but also in the pre-hospital setting. And these are some receiver operating curves as well. So as you can see here, end tidal CO2 is the green, right? So it's outproducing Q-SOFA. And then the red is end tidal CO2 and Q-SOFA. So you get minimal improvements when you combine Q-SOFA and end tidal, but end tidal by itself outproduces Q-SOFA by itself. So this is for sepsis, and this is for severe sepsis, right? And then a receiver operating curve, area under the curve of 0.78, and then 0.66. So not only can we use end tidal CO2 for identifying and diagnosing sepsis and severe sepsis, we can also correlate it to lactate and acidosis as well. So good old Hunter again took pre-hospital vitals, end tidal, and then correlated that to what their lactate was when they first came into the hospital, and also what their bicarb was. And you can see here that patients with lower CO2s had lower bicarbs, and then there's a trend line here. And a correlation coefficient of 0.429, that's a moderate correlation with lower end titles and lower bicarbs. Similarly with lactate. So you can see here, lower end tidal CO2s had some higher lactates. Correlation coefficient was a little bit less, but still mild to moderate correlation with that. And this is another study basically comparing, again, end tidal CO2 while labs were being drawn in the emergency department in sepsis, severe sepsis, and septic shock. So I want to pay attention to the gold and green lines here, the trend lines. Pretty stark between low end tidal CO2 and higher lactates. So sicker patients had correlated more to lower end tidal CO2s. Okay. And as you can imagine, with lower end tidal CO2s, higher lactates, more acidosis, these patients have higher mortalities. So again, these are receiver operating curves of end tidal CO2 outproducing vital signs for mortality in different studies. So area under the curve of 0.76 and 0.7, again, outproducing any other vital sign that you can see. And then one more time for good measure. So end tidal CO2 correlating just as well as lactate in mortality. Okay, so end tidal CO2, in my opinion, is a non-invasive lactate, the way that I'm viewing this now. So can we utilize that in the pre-hospital setting or early in the resuscitation to see how this patient's perfusion is doing? All right. And this is the last study showing that the predictors of mortality were mechanical ventilation pressors and then a low end tidal CO2. That's not going. Excuse me 1 second. Okay. There we go. Okay. So once we have a diagnosis of sepsis, and once we think that this patient is sick, we can also utilize end tidal for fluid responsiveness. So in the emergency department, even in the ICU, what we normally do, we've been shown that passive leg raise can simulate a fluid bolus, or we can just do a small fluid challenge and use dynamic measures, velocity time interval with a bedside echo, pulse pressure variability with an A-line, to see if that's going to affect hemodynamics. Problem is you need an echo with a program to calculate VTIs. You need an arterial line to calculate that. Why not do it with end tidal? Again, non-invasive, you could hook it up to the ventilator and check your fluid responsiveness with that, because you're isolating out your cardiac output for that. So in this study, they did a study, 65 patients, and said that patients who had an increase in cardiac output by 15% with passive leg raise were considered fluid responders. So in those patients, they did a passive leg raise, saw if they were fluid responders, and then fluid challenged them and monitored their end tidal CO2. So if their end tidal CO2 increased by 5% during the passive leg raise, they were found to be 100% specific to be a positive fluid challenge and were receptive to volume. And that, again, another receiver operating curve. So passive leg raise showing increases in cardiac index. It has the best area under the curve. End tidal CO2 changes right next. And then it outproduced arterial pulse pressure variation. So this is arterial pulse pressure variation here. So it outproduced changes in arterial pulse pressure variation. All right. And this is another study done in the Turkish ICU. So in Turkey, very similar. They took 100, They took 108 patients. 108 patients said that if there was a 15% increase in cardiac output, they were fluid responding. If the end tidal changed 4%, you had specificity and sensitivities in the 80s. If it changed 5%, specificity became 99%. And an area under the curve of 0.89. Again, outproducing systolic blood pressure changes, heart rate changes, and pulse pressure variation. So end tidal is this red line here, with an area under the curve close to 0.9. And this is a meta-analysis comparing fluid responsiveness with end tidal CO2, and yet another receiver operating curve showing everything's pretty much clustered in the upper left-hand quarter, which is where we want, with a pooled sensitivity of 0.79 and a specificity of 0.9. So it's really useful. The caveat being, in my opinion, that we have to really control for constant, consistent ventilatory status. So ideally, these patients were all intubated to give you a very consistent tidal volume and consistent dead space. And also their metabolism was relatively unchanged as well. So controlling those two pillars from the journey of CO2 slide, we can kind of isolate cardiac output and then fluid challenge based off of that. Okay. All right, so for sepsis, low end tidal CO2 can identify sicker patients, can identify sepsis and severe sepsis so that we can start resuscitating earlier and perform just as well as any vital sign and a lactate. And then once we have them, if they're super sick and can isolate and control their minute ventilation and tidal volumes, we can use end tidal CO2 to determine fluid responsiveness. There are actually other studies that show end tidal CO2 faring pretty well, similarly to sepsis, with DKA and other metabolic acidoses as well. So I've taken you through the pre-hospital setting, I've taken you through the early resuscitation setting, and how even the ICU and the intubated patient can utilize end tidal to identify sick patients, to improve patient care in sick patients. And we're taking it home by rehashing their learning points. So capnography determined by the pillars of metabolism, cardiac output, and ventilation, or the lungs. Dead space can contribute to that and separate that out with the CO2 gap. You need to keep that in mind when you're monitoring and using CO2, end tidal CO2. In procedural sedation, you're going to have decreased hypoxic episodes and assisted ventilations. And for intubation, please try to use it. Please try to use it. Please try to use it. You get immediate feedback. If it's in, you get the right tracing, and it's very, very helpful and useful. For cardiac arrest, if it's low in the beginning, try to improve your compressions. If it stays low, you're in trouble. It portends a poor prognosis. If you see a sudden rise in end tidal CO2, maybe a good idea for a pulse check to see if you regain ROSC. And for sepsis, consider it as another use of a non-invasive lactate. And if you can, see if it'll go up or the fluid challenge. So next time you have a patient in the ED, try not to waste their breath and think of using end tidal CO2. That's it.
All right, thanks so much, Nick. Let me first turn to Dr. Chu. Do we have questions online?
Yes, we have two questions. The first question is, we chase lactate in terms of our resus. Do you ever just use end tidal solely in terms of guiding your own resus in your own practice?
So I didn't before doing research on this topic, and I'm thinking about actually utilizing it in the sick patients that, again, probably would screen positive for sepsis or severe sepsis.
And the second question was, since end tidal can be low in cardiac arrest, should this not be used as confirmation for those patients who are in arrest and have been intubated in the field?
So when someone comes in cardiac arrest and the end tidal CO2 is low, we can utilize the tracing, so the capnography, so the waveform, in determining whether it's in the right place or not. So your capnometry, the number might be low, but the waveform will show the appropriate shape to tell you that that it should be in the right place. If the waveform is not the right form, then I would consider adjusting and assuming it's not in the right spot and reintubating.
All right, questions in the room?
Yep. So I appreciate that for sure. Oh, go ahead. So basically, so the question was in a non-intubated patient with the end tidal already itself being a number that's anywhere between 20 and 50, 5% of that is a very small change. So how do we account for that? What does that look like? So in a lot of these studies that predicted end tidal changes for passive as fluid responsiveness, a lot of them were intubated. So you can control and get very consistent tidal volumes, minute ventilations, and you can isolate out the cardiac output component of the end tidal CO2. So if you do your fluid challenge, they're intubated. Again, you're just attaching the end tidal to the ventilator. They're synchronous with the vent. They're having the same tidal volumes. Presumably a fluid challenge, if you do see that change in a couple of breaths, you'll see it within 10 minutes, within 10 breaths or so. Actually 10 breaths or so. So if you see that go up after you deliver your passive leg raise maneuver or a fluid challenge, then I would say that that's considered positive. Is there data on patients? Not much, no. And truly there's a lot of variability with breaths and stuff like that, especially if they're sick. You presume that they're a little bit tachypnic, things like that. I probably wouldn't use it for that.
You were mentioning that there are places obviously that aren't using this. Did you find why? Is it like a cost problem? Is it a systems-based problem?
Yeah, I don't know what that is. So a lot of the hospitals didn't have it readily available. So the question is why are a lot of these hospitals not utilizing capnography in the study where it showed that they were not using it? So some of them it just wasn't readily available, and a lot of people, I guess, aren't used to grabbing that for intubations. They're used to auscultating. They're used to the colorimetry. It's in a lot of intubation carts too. So I think that's just the normal run-of-the-mill, like what we're ingrained with. And I'm not gonna lie, early on in my training, I wasn't using it very much. So as I've gotten out, I wanna use it more and more to confirm tube placement.
Is it expensive? Yeah.
I don't think it's very expensive. I think it's mostly plastic and then the sensor. I don't think it's very expensive to do.
All right, I know Dr. Whitting had a question, but what we will do is we will have an opportunity in the room once we end our critical care symposium to continue to ask all of our speakers a few questions. So with that, thanks so much, Dr. Santavicca.